Good day, everyone. So good for you to join us. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health in the United States. It's my pleasure to welcome you to our webinar today. The coalition was started several years ago by the task force based on their experience in disease elimination and recognizing the new elimination goals for hepatitis. We launched the coalition as a community of practice, bringing people together to connect, to share their experiences in their efforts to eliminate hepatitis around the world, for us to assist that effort with expert technical assistance, building a strong evidence base, and then mobilizing all aspects of society needed to achieve our goals for hepatitis elimination. And I look forward. Please visit our website at globalhep.org to learn more about the coalition, and also to collect and to find all the information about this webinar series that you'll be participating in the third series of today. We're going to be talking really about one of the most powerful and one of the most effective interventions to prevent disease in the history of medicine, and that's the hepatitis B vaccine. Indeed, a recent model estimates that 22 million deaths have been averted since 1990 because of the increasing coverage with hepatitis B vaccination for young children. Unfortunately, and what brings us together today is that coverage is lowest in the countries of the WHO AFRO region, particularly around birth dose vaccination, which is the critical intervention needed to interrupt mother-to-child transmission, which confers a 90% risk of chronic disease and 25% risk of premature mortality from liver cirrhosis and liver cancer in later life. This is our third time to come together. Our first meeting was to bring the international organizations working in the field of prevention of perinatal hepatitis B transmission in Africa together with their local colleagues to share what they're finding in those various efforts. Our second webinar was to provide a forum for immunization programs to describe how they're working to implement and integrate birth dose hepatitis B vaccination into maternal and child health programs in the countries of Africa, or the challenges in that regard. Thirdly, and today, we're going to talk about a very important step toward that scale up of hepatitis B birth dose vaccination, and that is policy development. And how can the role of NITAGs in developing strong policies for birth dose implementation. And we're going to be talking about what kind of toolkit can we at the coalition in collection with all of you on the webinar today and other partners can bring together to help NITAGs work through that process of implementing, of developing policies for birth dose vaccination. So this webinar is very much in keeping with our overall mission of promoting information sharing through peer-to-peer collaboration, recognizing ways that we can help with technical assistance, which is our subject today is this NITAG Toolkit. And then through all of those efforts, by working together, build the capacity to scale up this critical intervention to protect infants from chronic hepatitis B infection. I look forward to our discussion later on. These are our objectives for today, where we'll be sharing our products of technical assistance, where we will be hearing from countries that have gone through the NITAG process for hepatitis B vaccination. What process did they use? Having a discussion opportunity regarding those processes, hearing from other countries. And then my colleague here at the coalition, Dr. Henry Njuguna, outlining the toolkit we're developing to receive feedback on that toolkit so we can continue to refine it so it'll be as helpful to all of you as possible. And then we will have a fourth webinar next month to discuss next steps regarding the technical assistance that the coalition and other partners can provide. Please, I encourage you all to participate in the discussion. Please use the chat to share your thoughts, as well as your questions. And I'll turn it over now to my colleague, Lindsay Hebert, to describe more information about the webinar and the other housekeeping items. Lindsay.
Good morning, everyone, or good afternoon to many of you, and thank you for joining us. Just a few quick housekeeping items. If you have any questions or concerns throughout the webinar, feel free to chat me or email me at lhebert, HIEBERT@taskforce.org. So this meeting, we do have simultaneous interpretation available for both French and Portuguese. I imagine many of you are familiar with this option in Zoom by now, but if you are not, there will be a little globe at the bottom of your Zoom screen that you can select, and then you can choose either French or Portuguese to listen in that language. I encourage those listening in English to also choose English, as there will be a couple of presentations in French that you'll want to be able to hear the English translation for. We also encourage you to update your Zoom name to give everyone an idea of where you are in the world. So feel free to edit it to add your organization affiliation or your country. To do that, you go to the participants list, which again is at the bottom of your Zoom navigation bar. You select your name and right click it, and you'll have the option to edit your name, rename there. And this is just an example of what you could change that to. I have US, where I am based in Atlanta, and the Coalition for Global Hepatitis Elimination, which is my organization. We encourage you to use the chat actively. In our previous meetings, we had a lot of active discussion here. And we also take all the questions posed in the chat and turn that into a question and answer document that we'll add to the webinar website page after this event, and also share it with you so you have it as a future resource. And if you have a question for a previous presenter, if you want to just indicate that by using @ sign or in some other way, that will help us direct the questions to the right speaker. And then lastly, just making you aware of the resources from the webinar, as John mentioned, and Henry will again review at the end of the meeting today, but all these sessions are recorded. They're all available on our website at globalhep.org. And along with the recordings, we have all the presentations from our great speakers. We also have individual videos from the speakers, and we have a meeting report that's developed after this that summarizes the presentations and the discussion. And I'll put in the chat where you can find those. And then lastly, the coalition has some other resources. We have a help desk related to all technical assistance requests that you're welcome to use following this meeting for any questions or requests for additional support. And we also developed a hepatitis B evidence base, hepatitis B birth dose evidence base last year that's also on our website that has a repository of systematic reviews related to this topic that you might find of interest. And so I'll stop there. And again, please feel free to send any questions on using Zoom in the chat to me. Thanks so much.
Thank you, Lindsay. I'll now turn it over to my colleague, Henry Njuguna. Henry?
Oh, thank you very much, John and Lindsay, and thank you and welcome you all participants for this meeting. We really appreciate your time. So today we are going to discuss a couple of things. We are going to have Dr. Abigail Schaefer from CDC talking about the role of NITAG, the introduction of new vaccines. Thereafter, we'll have Dr. Sidin Diaye from WHO AFRO talking about the AFRO NITAG overview. We have Professor Anta Taldia, who is from Senegal, who is going to tell us about their NITAG experiences with dealing and making a recommendation with hepatitis B vaccine. And that will be followed by Dr. Gona from Zimbabwe, who have also made a recommendation, and we'll be hearing their experiences in the process. Next slide, please. We'll have a panel sessions, and we have invited several speakers to also participate and share their experiences in their respective countries. These are NITAG members. We have Dr. Jean Kabore, we have Professor Tiambre Isaka, we have Professor George Amar, And you have Professor Rose Barnett and Dr. Melinda Sachard, who are also going to share these very important lessons that they've learned in the whole process of either planning to, or they have actually done the whole process of making a recommendation for the introduction of hepatitis B vaccine. I'm going to follow by discussing about the toolkit that we are discussing, and really this is a subject matter of today, and I will welcome a lot of comments and feedback about this particular presentation. Then as we wind up, we'll have a question and answer session, and then we'll talk about the next meeting and finally close up the meeting. Next slide, please. Lindsay, are you able to project the?
Oh, absolutely. I wasn't sure if you wanted to share.
Okay. Oh, thank you. So I'm going to give a brief overview of the previous meeting, just to make sure that we are all at par in terms of what we've been able to discuss so far. We've had, next slide, we've had two previous meetings in the past. The first meeting was in March 17 and 18. We had 2 days because it was a very long and comprehensive meeting. And that particular meeting, just go back to the previous slide. In that particular meeting, we provided updates from research partners and technical partners on the activities related to hepatitis B birth dose vaccine in Africa. We had CDC, WHO, the coalition, who provided an update, the latest update on the introduction of hepatitis B birth dose vaccine and the status of birth dose programs globally and regionally, and the current priority research and technical assistance activities. Research partners and also technical partners also provided updates on their current and upcoming projects related to the hepatitis B birth dose. The second meeting was held on May 5th. And this particular meeting, we invited several Ministry of Health officials, including hepatitis B focal persons, as well as API officers. And these particular meetings, we wanted to learn as we build this community of practice from these officers who have been working on the ground on hepatitis B vaccine, to share their experiences related to that whole process. Countries that have already introduced the vaccine and those ones who are in the process of introducing the vaccines were able to participate and give us quite very detailed picture of the whole process and their experiences in implementing the hepatitis B birth dose vaccine. We had countries such as Botswana, Ethiopia, Ghana, Mali, Mozambique, and Nigeria and South Africa present during this meeting. Next slide, please. We had so far we've had about 24 countries represented by various participants. About 220 so far have registered and actively participated in this meeting. These participants have represented various organizations, including ministries of health as well as NITAG representatives. We've had WHO staff. We had technical and implementing partners participate, research partners, international funding agencies were also represented, as well as civil society members and others who were also welcomed from other aspects of professional affiliations. Next slide, please. If you missed the first two meetings, you're not all lost. These meetings have been recorded and they are available, plus reports, very detailed reports highlighting the key points from these particular meetings. And they're available at www.globalhep.org. This can be accessed through the internet, and you can be able to get all these materials. Next slide, please. So I'll give you a brief picture of what we have learned so far from the meetings that we've had in the past. We know that there are more than 60 million. In fact, this number has been updated, and this you're going to learn later on in this presentation. We have more than 60 million people currently living with chronic hepatitis B in Africa. And the prevalence is more than 6%. Which is very high compared to the rest of the world. Africa ranks second with that high prevalence. Hepatitis B virus infection during infancy confers the highest risk of chronic infection, and this predisposes them to suffer quite a number of complications, including liver cirrhosis, as well as hepatocellular carcinoma later in their lifetime. Unfortunately for Africa, despite the fact that there has been a vaccine that has been able to prevent, only 14 countries have been able to introduce the hepatitis B birth dose vaccine, which is very important in preventing mother-to-child transmission, which again, as I said, infection at that early stage results in the complications that I didn't mention. Africa has not been able to meet the 2020 interim goals. Currently, the whole world, we have had a prevalence of less than 1% hepatitis B surface antigen among children less than 5 years of age. And in the African region, we stand at 2.53%. Next slide. So some of the key takeaways from the previous meeting is that Africa faces quite a number of barriers towards the introduction, as well as the administration of a timely hepatitis B birth dose vaccine. And some of these barriers include poor coordination between the expanded program on immunization, as well as the maternal child health programs. And as well as there's a lot of home deliveries that make access to mothers who deliver and to the babies who are born and need the vaccine not be accessed. There is a need for awareness among policymakers on hepatitis B vaccine importance in eliminating mother-to-child transmission. And they also need to be aware that this is really a cost-effective strategy so that they are able to support it. There is need to build advocacy, to build local support amongst healthcare workers, to understand the importance of this vaccine, to understand why it should be given timely, and also to create advocacy amongst mothers when they're pregnant so that they can be able to demand the vaccine once they deliver their newborns. There's also need for funding, and we are happy that Gavi is in the process of trying to see how best they can be able to provide support for the introduction and scale up of this vaccine. Next slide. In today's meeting, like John mentioned, we are going to continue building this community of practice, and thank you so much for coming, because this is not our own effort, it's really a community approach. And we want to learn from you and also get the best practices from you so that you can be able to work together to making sure that we are able to achieve this strategy. We want to identify NITAG needs from countries that wish to introduce the hepatitis B birth dose vaccine. And also we'll be presenting a draft toolkit, like I did mention, on resources that can be used to support NITAGs in the evidence generation in support of hepatitis B vaccination recommendations. And we really would like you to give us as much feedback as possible on how best we can be able to improve on these resources. Next slide, please. Thank you so much, and very much welcome. Over to you, John, please.
Thank you. Thanks a lot, Henry. You'll be hearing more from Henry in a moment. We'll turn now to Dr. Abby Schaefer from CDC to discuss the role of NITAG.
Discutir os objetivos da NITAG.
Abby?
Yes, let's see.
Abby?
Hello. Hi, everybody.
Olá.
Thanks for inviting me.
Obrigado por me terem convidado para este encontro.
So next slide.
No próximo slide, por favor.
So I'm going to talk today briefly about the role of the NITAG in the introduction of
Vou
new
falar sobre o
vaccines.
papel do NITAG na introdução de novas vacinas.
Next slide.
Próximo slide, por favor.
I'm going to give a little
Eu vou
background,
falar um pouco sobre o background,
talk about benefits of
falar
having a
sobre o
NITAG in a
benefício de
general
ter
sense,
o NITAG,
discuss the role of the
e os
NITAG in introducing new vaccines, and talk about NITAG role in Immunization Agenda 2030. Should I go on? Is everything okay with the translation? There was some, I think it's,
Yes, I think we figured it out. Just one.
okay. Okay, great. Next slide. Yeah, next slide.
Next slide. Is this okay?
Yeah, next slide. Okay, great. Oh, yeah, no.
Which one? This one?
That one. Yes, that one.
Okay.
Great. So this is just a
Portanto,
figure from
isto é apenas
WHO.
uma.
Actually, now the simultaneous translation, I think, is, I can hear it. I can go on, but should I just continue?
Yes, please.
Okay.
Can we just
So,
give a 20-second pause? I think we just need
okay.
to fix
Okay,
it.
sure. No problem. Yeah, it's always tricky in these remote.
Okay, I think it should be fixed.
Okay, great. Okay, so NITAGs are part of the WHO Immunization Policy Advisory Framework, as shown on this figure. At the global level, of course, we have SAGE and WHO technical advisory groups, and these groups work mainly on global policy and recommendations and strategies. At the regional level, we have regional immunization technical advisory groups. And at the national level, we have the NITAGs, and these groups work on recommendations for national policies and strategies. So next slide. Thanks. So here we see a map of countries that have NITAGs in 2019, so our most recent complete data, and that have met some or all of the current WHO NITAG functioning criteria. And this map is actually taken from the NITAG Resource Center, which is a really great resource, and the link is noted on the slide. There's a lot of information on this resource center. And you can see that most of the remaining countries without NITAGs or not meeting all criteria are located in the African region. And in 2019, overall, globally, there were 170 countries that had established a NITAG, and 123 had met all criteria for a minimally functioning NITAG. So quite a bit of work to do, and some of the regions have a little bit more work to do. So next slide. So this is just a reminder, what is a NITAG? It's a body of national experts that provides technical and scientific guidance to the government on immunization policy, norms, and practices. So in this way, the NITAG is both a technical resource and a deliberative body to empower the national authorities and policymakers to make evidence-based immunization-related decisions. And the basis of the decision-making is disease epidemiology, clinical characteristics, vaccine and immunization characteristics, sometimes economic considerations, as well as political and public health considerations. So this is particularly important in view of, complex and vast bodies of evidence we have, the need to adapt recommendations to the local context, and the global interdependence and integration of health systems. So next slide. Great. So here I just wanted to summarize, that NITAGs make really important contributions. So a NITAG contributes to robust and fiscally sound government decision-making through several ways. And it's just always good to really understand these so countries can advocate, strongly for NITAGs. So by increasing credibility of the government, by improving its capacity for rigorous evidence-based decision-making, minimizing pressure from outside interest groups, including industry and anti-vaccination groups. This is very important. By providing transparency, by eliminating real or apparent personal conflicts of interest. And in the event of an adverse event from immunization, NITAGs can be really important in neutralizing public backlash. So next slide. Great. So here we see the NITAG traditional process a NITAG goes through. And just for a review, you know, when it makes a recommendation to introduce a new vaccine or really anything related to vaccination, it doesn't always have to be a new vaccine. So at the beginning, there's a broad policy question received from the Ministry of Health. And this policy question is then refined and focused using the PICO technique. Please do another click. Yeah, great. So that uses the PICO technique, population intervention comparison outcome, to define the framework and criteria that are going to be evaluated. Next click. Then the full NITAG, then the Secretariat supports a working group or a designated part of the NITAG, if the NITAG doesn't have working groups, to gather the evidence and analyze the findings. Next click. Then the full NITAG needs to discuss and draw conclusions and finally make a recommendation. So the Ministry of Health takes this, next click, takes this recommendation and then decides whether or not to adopt the recommendation and how it will be implemented. And normally this process takes from 1 to 2 years, and always important to remember that the Ministry of Health is always the decision maker on adopting a recommendation. So next slide. And just because we are in the middle of a pandemic, there are some differences in the process that has occurred with the COVID-19 vaccine. And the steps are basically the same, but there are some important differences, mainly in that the NITAG is working with much more limited data. And there's usually limited supply of the vaccine, at least early on. And this necessitates the clear identification of priority groups. You can do the next click. So priority groups for vaccination, depending on the phase of supply. In the next click. Also interim recommendations, you can do another click. Also interim recommendations are often made, which are refined as more data becomes available. And so, you know, usually there may be recommendations that are updated or changed and routinely for NITAGs, but for COVID-19 vaccine, this has been much more emphasized. So the two main differences, the whole process is usually completed in less than a year, which has been seen for COVID-19, and there are much more frequent meetings of the NITAG. Okay, that's just a little background on the process. And next slide, please. So I wanted to bring up one other issue that NITAGs may be involved in the introduction of new vaccines, and this is concerning vaccine confidence and vaccination coverage. And we usually like to think about the vaccine confidence continuum, with vaccine hesitancy being one part of that. Now here in this slide, I mentioned vaccine hesitancy because it is how it is often referred to in the published literature. And WHO placed vaccine hesitancy as one of the top 10 threats to global health in 2019. But I think we are trying to talk more about vaccine confidence and demand. Because we think it does capture these issues better. So NITAGs play an increasing role in advising governments on approaches to address confidence and improving coverage. So several reasons why NITAGs are positioned to be so important is because they use evidence-based decision-making, they're multidisciplinary, they're transparent, and they seek stakeholder input. And this is really important in dealing with vaccine confidence issues. So NITAGs have made recommendations, for example, on action plans for improving vaccine confidence with locally customized applications. And those are culturally sensitive, culturally appropriate. And these include such things as you've probably heard about this, tailoring immunization programs or TIP. And this is like a toolkit for addressing, understanding reasons for poor vaccination, poor confidence and lower uptake of vaccines, and then developing interventions. NITAGs have also debated the issues on mandatory vaccination and made recommendations and for or against these requirements. And there's been very diverse outcomes for countries on this. Some countries do have requirements, some don't. And there are just some resources at the bottom. So this is a really important issue and one that NITAGs really have become somewhat involved in. So next slide. Let's see. So, sorry. Oh, so for as far as immunization agenda or IA 2030, NITAGs play a pretty prominent role in that. So NITAGs are involved in Strategic Priority 2, which includes commitment and ownership and accountability. And one of the key areas of focus under commitment and demand is to strengthen evidence-based decision-making with input from technical groups such as NITAGs. So they do play an important role in that aspect. Implementation of IA 2030 will be supported by technical input from experts, including NITAGs and RITAGs, and will build upon guidance from SAGE to help ministries of health prioritize programmatic areas. So they also play an important role there. Strategic priority objective indicators. There are indicators as part of IA 2030, which will be used to monitor progress. And mechanisms for analysis and interpretation of indicators will be developed, and platforms for regular evaluation will also need to be developed. And these will likely include SAGE meetings, RITAG meetings, and NITAG meetings. So these are all going to be areas where progress is presented and discussed, and maybe recommendations for how to make improvements. So specifics are really under development, and these will all be country specific at the end. But it's good to remember NITAG role in IA 2030. So next slide. And that's really all I was going to talk about. And I am very happy to answer any questions. And somebody also put in the chat about sharing slides, and that would be great. I'd be happy to. Are there any questions? It was just a very general background, but obviously NITAGs that's the whole reason for this discussions later today.
John, you're muted.
Thank you, Abby. Please hang around. There might be some more questions later on.
Yeah,
In the
sure.
Thank you again.
Yeah, thank you very much.
Yes, right. We'll now turn to Dr. Sidi Nahaye, who's the technical officer from the AFRO, WHO AFRO, and he'll be giving us some update of the status of NITAGs in the AFRO region. Sidi?
Thank you, John. So I will proceed in French. The slides are in English. Merci donc surtout aux NITAG qui sont.
1 second, Sidi. For those of you that were listening English, just make sure that you've selected English in the interpretation, and give the translators a second to switch their line.
Thank you. Can I proceed?
Try to proceed. Thank you.
Donc, je disais merci au Global Health Task Force par rapport à ce webinaire à l'endroit donc des NITAG, d'AFRO, mais aussi au CDC qui accompagne donc la région africaine dans tout ce qui est implémentation donc de la vaccination, mais aussi dans d'autres domaines. Et principalement aussi, merci aux NITAG qui ont donc joint ce panel pour pouvoir partager leur expérience dans l'introduction du vaccin contre l'hépatite B à la naissance. Slide, please. Slide. Alors, globalement, les NITAG ont... Slide, please. Donc, globalement, les NITAG ont déjà eu droit à cette présentation. Mais comme dans le panel, il y a donc le Global Task Force pour l'introduction du vaccin hépatite B à la naissance et d'autres partenaires qui sont donc dans ce panel-là qui n'ont pas eu à voir un peu par rapport à nos webinaires précédents. La vue d'ensemble des NITAG au niveau de la région Afro. Et comme vous le savez, actuellement, on est dans l'agenda 2030 de la vaccination avec comme vision un monde où toute personne, quel que soit donc son lieu de résidence et quel que soit son âge, puisse donc bénéficier pleinement des vaccins pour une bonne santé et un bien-être. Et par rapport à cela, on a des objectifs d'impact, à savoir continuer donc à avoir cette réduction de la mortalité et de la morbidité liées aux maladies évitables par la vaccination, et ceci tout au long donc, de la vie. Mais aussi, il est question de pouvoir agir sur l'équité en termes d'accès, en termes d'utilisation entre le milieu urbain et le milieu rural, mais aussi entre les pauvres et les riches, mais aussi selon le niveau d'éducation, pouvoir donc avoir accès aux vaccins, que ce soit les vaccins qui existent déjà dans les programmes de vaccination, mais aussi les nouveaux vaccins donc, à venir. Donc, s'assurer aussi qu'il y ait donc, une bonne santé et un bien-être pour tout le monde, en renforçant donc la plateforme, les systèmes de vaccination et en l'intégrant dans les soins de santé primaires pour pouvoir contribuer donc à l'accès universel donc, et à la couverture sanitaire universelle. Slide. Alors, globalement, nous avons connu vraiment des avancées notables pour l'établissement des NITAG dans la région africaine. Si vous prenez le départ, donc pour le graphique en haut à gauche, 2013, qui est un peu l'année de départ de CIVAC, qui supportait donc la région africaine pour la mise en place de ces organes que sont les NITAG dans les pays. Donc, on était par rapport à l'année 2013, environ 12 pays qui avaient des NITAG. Aujourd'hui, à l'heure actuelle, donc au 31 mai 2021, on est à 37 pays qui disposent qui ont mis en place donc un NITAG. Donc ceci est vraiment une avancée majeure. Vous voyez entre 2019 et 2021, donc on a eu 7 pays vraiment qui ont eu à donc mettre en place leur NITAG. Et par rapport aussi aux critères basiques de fonctionnalité des NITAG, donc là, nous sommes passés de 8 pays qui avaient donc rempli tous les 6 critères de fonctionnalité définis par l'OMS, à savoir donc avoir une base législative ou administrative, avoir donc des termes de référence écrites, avoir donc au moins 5 domaines d'expertise, mais aussi se réunissent au moins une fois durant l'année, ainsi que la transmission de l'agenda et des documents liés à quelconque réunion du NITAG au moins une semaine aux participants. Mais aussi que les NITAG puissent, les membres donc, principaux puissent signer les formulaires de conflit d'intérêts avant chaque activité. Donc là, on est actuellement donc, à 25 NITAG sur les 37 qui remplissent donc, ces 6 critères de fonctionnalité des NITAG. On a encore certains pays qui n'ont pas établi de NITAG, à savoir, nous avons 4 pays en Afrique de l'Ouest et les 6 pays donc, de l'Afrique centrale. Et là, il faut saluer vraiment l'Afrique de l'Est et du Sud qui ont achevé à ce moment, en 2021, l'établissement des NITAG dans tous les 20 pays donc, qui composent l'IST de l'Afrique de l'Est et de l'Afrique du Sud. Diapo. Alors ça, c'est une vue d'ensemble donc de ce qui est établissement et critères de fonctionnalité. Il y a actuellement des slides. Il y a actuellement donc des activités qui sont en cours, que ce soit au niveau donc de l'OMS, mais aussi au niveau des partenaires qui soutiennent donc les pays dans la fonctionnalité des NITAG. Actuellement, nous sommes en train donc de mettre en place et d'adapter ces outils de formation des NITAG, à savoir l'outil qui était qui a trait au rôle, à la composition, au fonctionnement, mais aussi aux outils de fonctionnement que les NITAG doivent utiliser. Donc ça, c'est un module qui a été mis à jour et qui a été donc partagé avec les pays. Mais pour ce module aussi, on a un autre module qu'on a ajouté, c'est surtout tout ce qui est lié à la gestion des conflits d'intérêts au sein du NITAG pour pouvoir émettre des décisions claires, indépendantes et sans biais. Ensuite, il y a d'autres modules qui sont en train d'être développés toujours par le Global Task Force. C'est des modules qui ont lié au processus d'émission des recommandations basées sur des données factuelles. Et la nouveauté, c'est que ce sera des modules, donc pour un premier temps, qui seront disponibles en ligne. Donc, les premières formations, certainement, vont se faire en ligne. Et actuellement, on est en train d'identifier des pays qui peuvent accueillir cette formation pour les NITAG. Et le CDC aussi est en train, donc, avec la participation donc, de l'OMS et d'autres partenaires, de mettre en place un outil pour évaluer la maturité donc, des NITAG à travers différents critères qui ont été identifiés. Donc, je pense que c'est un matériel qui sera certainement disponible d'ici la fin de l'année. Mais aussi, il y a tout ce qui est activité de support au pays par rapport à l'introduction du vaccin COVID, des vaccins COVID, mais aussi des autres introductions de vaccins qui sont programmées dans les pays. Donc, dès que l'OMS reçoit les requêtes des pays, donc là, nous sommes ouverts à appuyer les pays dans ce sens. Slide. Slide, please. Alors, l'autre plateforme qui est disponible actuellement au sein donc le lien est en bas de la diapo, au sein donc du site web NITAG Resource Center. Donc c'est un site, un onglet nommé SysVac, donc qui a été un projet qui a été développé donc par l'Institut Robert Koch d'Allemagne, mais aussi l'OMS. Donc, c'est un projet qui a pour but de pouvoir faire des revues systématiques sur des priorités liées au vaccin. Donc, actuellement, ce que nous avons sur le site, c'est des revues systématiques concernant les vaccins COVID-19, mais aussi, durant cette année, il y aura d'autres maladies qui seront identifiées, d'autres vaccins prioritaires, et des revues systématiques sont effectuées concernant donc l'efficacité des vaccins, concernant l'innocuité, mais aussi toutes les questions qui ont lieu par rapport surtout aux connaissances, attitudes et pratiques liées à l'utilisation des vaccins. Donc, je pense que vous pouvez utiliser ce lien pour pouvoir voir qu'est-ce qui est disponible actuellement sur ce site. Diapo, slide, please. Alors, on a différents challenges liés à l'activité des NITAG. Vous savez qu'en 2017, avec la déclaration d'Addis Abeba, il y avait un engagement des pays à mettre en place des NITAG fonctionnels. Donc, actuellement, nous, en 2021, nous n'avons pas encore atteint cet objectif de pouvoir mettre en place des NITAG partout. Il y a aussi le challenge lié à l'intégration du NITAG, des activités du NITAG dans le processus décisionnel des systèmes d'immunisation dans tous les countries, dans tous les pays. Dans certains pays, ils ont réussi à le faire, mais dans d'autres encore, on a vraiment des goulots d'étranglement à lever pour pouvoir aboutir à cela. Il y a toujours le point par rapport au financement des activités des NITAG. Là aussi, certains NITAG, donc le financement dépend de partenaires, et ceci pose une question aussi d'indépendance par rapport aux décisions que les NITAG donnent. Mais aussi au renouvellement des mandats de certains NITAG. Et ceci est très difficile dans certains pays parce que le panel d'experts n'est pas très élargi. Du coup, donc, le renouvellement, souvent, ça prend du temps. Ce qui est mis dans les TDR, malheureusement, ce n'est pas ce qu'on voit en fait sur le terrain par rapport au renouvellement donc, des mandats des NITAG. Il se pose aussi la question par rapport aux ressources humaines qui sont affectées par le ministère de la Santé aux activités du NITAG, à savoir aux activités du secrétariat technique. Donc, dans la plupart des pays, nous avons des difficultés d'avoir tout le temps du personnel qui est disponible pour appuyer le travail du secrétariat technique, qui, je le rappelle, est la cheville ouvrière vraiment des activités du NITAG. Il y a toujours les challenges liés, les défis liés donc, à la disponibilité des données locaux, des données locales au niveau des pays, mais aussi pour vraiment pouvoir avoir des données suffisantes et qui sont contextualisées pour avoir des recommandations fortes de la part des NITAG. Souvent, ces données locales peuvent manquer. Je pense qu'en 2020, les NITAG ont été confrontés à ce délai qui a été raccourci entre la question formulée par le ministère de la Santé, la requête formulée par le ministère de la Santé et l'émission de recommandations. Donc, ce délai-là vraiment a été raccourci par rapport aux vaccins qui sont utilisés en urgence. Donc, c'est les vaccins COVID. Nous avons vu quand même que les NITAG, certains NITAG ont pu vraiment faire des recommandations en un temps record, en moins de 2 mois. Ça, c'est vraiment des choses à féliciter. Mais certains NITAG ont toujours donc, cette difficulté par rapport à ces processus d'émission des recommandations dans un temps très court. Slide. Je pense à la dernière. Alors, comme prochaines étapes des activités qui sont suivies, c'est surtout le plaidoyer par rapport à ces pays qui restent à mettre en place donc, des NITAG. Et actuellement, Donc, nous sommes dans un processus donc, de communication de la directrice régionale vers les pays pour pouvoir vraiment faire porter ce plaidoyer pour que ces pays qui restent puissent mettre en place ces NITAG. Mais aussi assurer surtout le fonctionnement des NITAG qui sont mis en place actuellement. Donc, il faudra aussi voir par rapport aux autres matériels de formation pour que ces matériels puissent être disponibles d'ici donc la fin de cette année. Et comme vous le savez, il y a un projet avec l'Université du Cap, notamment le centre VACFA, pour mettre en place un pôle scientifique régional pour pouvoir appuyer les NITAG pour tout ce qui est production de données locales, pour tout ce qui est modélisation, mais aussi le renforcement des compétences pour pouvoir avoir des recommandations basées sur des données factuelles. Donc, c'est un projet qui est en cours et que nous espérons d'ici la fin de l'année ou plutôt en 2021 que ce projet puisse enfin démarrer. Donc, c'était ça que je voulais, je pense que c'était la dernière diapo, slide. Donc, c'était ça que je voulais partager avec l'assistance. Et merci encore. Over to you.
Thank you very much, Dr. Sidi, for that excellent overview, the status of NITAGs. I've been asked to ask the interpreters to switch back to French for my short comments here, and then switch to English for the next presentation. Dr. Sidi, you have a question to you in the chat. If you could respond to that in the chat, it will be greatly appreciated. And if needed, we will bring it up during the discussion period. It's now my pleasure to turn the podium over to Professor Anta from Senegal to talk about the NITAG process for hepatitis B birth dose implementation in the country of Senegal. Please, Professor Anta.
I believe you're on mute, Professor Anta.
Vous m'entendez?
Loud and clear.
OK, thank you. Donc, merci. Je remercie d'abord la coalition globale pour l'élimination de l'hépatite B de nous avoir invités à cette session. Nous n'avons pas assisté aux deux premières, mais nous ne manquerons pas d'aller visiter sur votre site ce qui a été dit. Ça a l'air très intéressant. Merci aussi à l'OMS AFRO et tous les partenaires pour le soutien qu'ils apportent au GTCV du Sénégal, qui est appelé ici Comité consultatif pour la vaccination et les vaccins au Sénégal. Prochaine diapositive, s'il vous plaît. Donc, nous allons vous parler du processus d'introduction de l'hépatite B à la naissance au Sénégal. Donc, nous allons commencer par vous présenter. Diapo, s'il vous plaît. Diapo. Diapo. Donc, voilà ce que nous allons faire. Donc, notre groupe technique consultatif pour la vaccination au Sénégal, nous l'avons appelé Comité consultatif pour la vaccination au Sénégal. Et il a été créé par un arrêté ministériel le 1er mars 2013. Il a été parmi les premiers GTCV mis en place. Donc, c'est un organe consultatif qui est chargé d'émettre des avis et des recommandations scientifiques et techniques qui peuvent guider le ministère en charge de la santé dans la définition, la mise en œuvre, le suivi et l'évaluation des politiques et stratégies nationales de vaccination. Diapositive, s'il vous plaît. Donc, ce comité consultatif pour la vaccination a diverses responsabilités. Entre autres, il doit faire l'analyse des politiques et des stratégies nationales de vaccination en cours, que ce soit dans le programme élargi de vaccination ou bien dans les activités de vaccination supplémentaires, et éventuellement proposer des réaménagements. Il doit également proposer des stratégies optimales pour le contrôle de toute maladie à prévention vaccinale. Il doit conseiller les autorités nationales sur les stratégies pertinentes pour le monitorage et l'évaluation de l'impact des programmes de vaccination. Il doit également présenter aux autorités nationales les derniers développements scientifiques et les innovations dans le domaine de l'immunisation et des vaccins. Il doit également faire un plaidoyer en direction des autorités nationales, de la société civile et du secteur privé pour soutenir, renforcer et crédibiliser les politiques nationales de vaccination. C'est très important dans cette époque où on est face à l'hésitation vaccinale. Et il doit promouvoir également l'établissement de partenariats avec d'autres comités consultatifs pour la vaccination, que ce soit au niveau national ou bien international. Donc, c'est ce que nous avons fait dans la sous-région d'Afrique de l'Est. Diapositive, s'il vous plaît. Diapositive, s'il vous plaît. Donc, ce comité consultatif pour la vaccination au Sénégal est composé de divers types de membres. Il y a d'abord ce qu'on appelle les membres de droit, qui sont au nombre de 15 personnes ressources de nationalité sénégalaise et qui sont dotés d'une expertise avérée dans les domaines suivants. Donc, nous avons la pédiatrie, l'épidémiologie, les maladies infectieuses, la santé publique, la bactériologie, virologie, l'économie de la santé, la socio-anthropologie, la gynécologie, l'immunologie, la vaccinologie, la médecine interne et la communication. Et ces membres de droit sont les seuls habilités à se prononcer sur les avis et les recommandations à l'intention des autorités. Ces membres, ces fonctions sont bénévoles et leur mandat est de 4 ans, renouvelable une seule fois. Diapositive, s'il vous plaît. Diapositive, s'il vous plaît. Donc, à côté de ces membres de droit, nous avons ce qu'on appelle les membres ex-officio et les membres de liaison. Les membres ex-officio représentent au sein du comité les services du ministère de la Santé, mais aussi d'autres ministères qui sont impliqués dans la mise en œuvre et le suivi des activités de vaccination, tels que le ministère des Finances, etc. Nous avons également les membres de liaison qui représentent les organisations et les institutions nationales et internationales qui apportent un appui dans le cadre de la mise en œuvre des activités de vaccination. Donc, nous avons l'UNICEF, nous avons Gavi, nous avons le CDC, etc. Diapositive, s'il vous plaît. Et pas des moindres, le secrétariat scientifique du comité. Tout à l'heure, le docteur Ndiaye en a parlé, c'est la cheville ouvrière. Donc, ce secrétariat scientifique et technique du CCVS est assuré par la direction de la prévention du ministère de la Santé. Donc, le ministère de la Santé nous envoie des personnels pour nous appuyer. Et ce secrétariat est chargé de la préparation et de l'organisation administrative et technique des réunions du comité et des sous-groupes de travail. Et également chargé de la rédaction, la transmission, l'archivage de toutes les productions scientifiques et administratives du comité, telles que les avis et recommandations, les procès-verbaux de réunion, etc. Donc, ce CCVS se réunit une fois par trimestre. Donc, 4 fois par an, nous avons une réunion institutionnelle, mais toutefois, il peut se réunir de manière extraordinaire à la demande du ministère, à la demande du président du CCVS ou bien la moitié au moins de ses membres. Et je souligne ici qu'à chaque réunion, les membres sont tenus de signer une déclaration de non-conflit d'intérêts. Diapositive, s'il vous plaît. Et également, les réunions sont confidentielles. Diapositive, s'il vous plaît. Donc, les sources de financement de ce CCVS. Tout à l'heure aussi, on a parlé des difficultés de fonctionnement, puisque les membres travaillent à titre bénévole. Le budget de fonctionnement du CCVS est pris en charge par la direction de la prévention du ministère de la Santé. Donc, à sa création, le CCVS a bénéficié de l'appui financier de partenaires tels que l'initiative CIVAC, on en a parlé tout à l'heure, l'Organisation ouest-africaine de la santé, Gavi, etc. Et à l'heure où je vous parle, nous avons certaines recommandations qui ont été toutes prises en compte par le ministère de la Santé. C'est l'introduction des vaccins contre le méningocoque. Donc, on nous avait proposé le méningocoque, mais nous voulons que ce soit le quadrivalent. Ensuite, la vaccination contre la grippe saisonnière, contre l'hépatite B, en particulier l'introduction de la dose à la naissance, le vaccin injectable contre le poliovirus et la vaccination contre la COVID-19. Et toutes nos recommandations ont été suivies par le ministère de la Santé. Diapositive, s'il vous plaît. Donc, en ce qui concerne maintenant l'introduction de l'hépatite B à la naissance, donc nous avons eu une saisine, c'est le ministère de la Santé et de l'Action sociale qui nous a posé la question suivante le 28 mai 2014. En quoi l'introduction d'une dose de vaccin contre l'hépatite B à la naissance est-elle pertinente dans le cadre du programme de vaccination en cours? Donc, il fallait répondre aux questions suivantes. L'opportunité et l'intérêt de la dose à la naissance. Comment le mettre dans le calendrier vaccinal, à quelle période d'administration? Et évidemment, les aspects opérationnels que ça va induire dans la mise en œuvre du programme élargi de vaccination. Diapositive suivante, s'il vous plaît. Donc, notre méthodologie de travail, donc nous avons créé un groupe de travail comme d'habitude. Chaque fois que nous avons une saisine, nous créons des groupes de travaux selon les compétences et les expertises nécessaires. Donc, de 10 membres appuyés par le secrétariat technique du CCVS avec les termes de référence suivants. D'abord, définir les éléments de base sur lesquels devrait s'appuyer la recommandation avec la méthode PICO, rechercher et analyser les données probantes sur ces éléments par une revue bibliographique la plus exhaustive possible. Ensuite, soumettre un rapport et des recommandations au CCVS pour la délibération. Donc, c'est ce groupe de travail qui va soumettre son rapport de travail et ses recommandations au grand groupe du CCVS qui va délibérer pour accepter ces recommandations ou bien les remettre en forme, etc. Diapositive, s'il vous plaît. Donc, à l'issue de ce travail, le groupe d'experts a d'abord recherché des évidences factuelles sur les questions qui ont été posées. D'abord, l'opportunité d'une dose de vaccin contre l'hépatite B à la naissance. Donc, la recherche de données probantes a porté sur d'abord l'infection. On a fait l'état des lieux sur l'infection du virus de l'hépatite B chez le nouveau-né. Quelle est l'importance de la transmission périnatale, d'abord du virus de l'hépatite B dans le monde, en Afrique et au Sénégal? Ensuite, quelles sont les stratégies de contrôle de la transmission mère-enfant du virus de l'hépatite B et la prévention du passage à la chronicité de façon globale? Ensuite, quelle est l'efficacité et l'innocuité de la vaccination à la naissance? Diapositive, s'il vous plaît. Donc, et aussi également les aspects économiques. Donc, c'est très important parce que il va y avoir des coûts supplémentaires qui vont être dus à l'introduction de ce vaccin. Donc, nous avons vu les aspects économiques avec le rapport coût-efficacité de la vaccination contre l'hépatite B à la naissance comparativement aux autres stratégies de contrôle de l'hépatite B. En deuxième point, le travail du groupe d'experts a apporté sur la période d'administration. Donc, quelle est l'efficacité de la vaccination à la naissance dans les 24 premières heures par rapport à tout autre schéma avant la 6e semaine? Parce que dans le calendrier du Sénégal, le premier contact se faisait à la 6e semaine, hein, en ce qui concerne l'hépatite B. Hein. Un troisième point, les aspects opérationnels. Donc, les données factuelles recherchées sont la stratégie qui permet d'obtenir une couverture vaccinale optimale de l'hépatite B à la naissance. Donc, avoir au moins 80 à 90% de couverture dans tous les districts sanitaires du Sénégal. Diapositive suivante. Le deuxième aspect opérationnel, c'est de passer en revue les présentations du vaccin monovalent qui sont disponibles. Et en troisième point, les facteurs qui vont favoriser l'adhésion de la communauté à la vaccination à la naissance. Donc, nous avons mené des recherches bibliographiques pour les évidences factuelles sur les bases de données de PubMed, de Medline, d'Inari, de Science Direct et la bibliothèque Cochrane. Donc, pour les articles pertinents et non libres d'accès, le groupe a dû faire appel à l'initiative CIVAC pour en disposer à partir de leur base de données. Parce que toutes les données bibliographiques n'étaient pas disponibles et nous n'avions pas de fonds pour acheter ces données. Donc, un rapport de recommandation a été présenté par le groupe de travail et après amendement, les membres de droit du CCVS l'ont adopté par consensus. Maintenant, diapo suivante, nous allons voir les éléments de la recommandation. Diapo suivante. Diapo suivante, s'il vous plaît. Donc, quelle a été la recommandation? Donc, le CCVS a recommandé au Programme national de vaccination de réviser le calendrier vaccinal et d'inclure l'administration d'une dose de vaccin hépatite B monovalent à la naissance. Nous avons insisté sur l'efficacité de la stratégie qui nécessite un taux de couverture vaccinale optimal des nouveau-nés. Et il fallait absolument qu'on ait au moins 90% de couverture, 80 à 90%. Et le CCVS recommande en outre de rendre disponible la vaccination dans toutes les structures de santé qui sont susceptibles d'abriter des accouchements, pas seulement dans les centres qui s'occupent des nourrissons. De renforcer ainsi les consultations prénatales en volume et en qualité, pour pouvoir mettre la main sur tous les nouveau-nés. En ce qui concerne les accouchements faits à domicile, donc vous savez, dans nos pays en développement, il y a encore un certain taux non négligeable d'accouchements qui sont faits à domicile. Là, il faut vacciner dès le premier contact avec une structure de santé et veiller également à la pérennisation de la stratégie de la vaccination à la naissance. Diapositive suivante. Donc, en conclusion, nous pouvons dire que le processus d'introduction de la dose à la naissance du vaccin contre l'hépatite B au Sénégal n'a pas rencontré de difficultés majeures. Cependant, donc, pour faire une recherche bibliographique exhaustive, notamment pour les articles qui ne sont pas libres d'accès, nous avons rencontré quelques écueils. Nous avons dû faire appel à nos partenaires de CIVAC. La spécificité de cette vaccination tient au fait qu'elle doit être pratiquée dans les 24 premières heures de vie. Donc, cela nécessite l'engagement non seulement du personnel qui s'occupe d'habitude de la vaccination, du programme élargi de vaccination, mais également du personnel qui s'occupe de la santé maternelle et infantile. Et également, tout ce pan de la population qui ne vient pas dans les structures publiques, mais qui va faire vacciner ses enfants dans le secteur privé. Donc, à ce titre, un plan d'introduction a dû être élaboré, incluant, diapositive, donc la révision, on a dû réviser les supports qui sont utilisés dans le programme élargi de vaccination intégrant le nouveau vaccin. Il a fallu élaborer du matériel de formation pour l'introduction du vaccin monovalent contre l'hépatite B. Il a fallu adapter les messages de communication, notamment pour mettre la main sur les nouveau-nés dans les 24 premières heures. Et il a fallu également élaborer du matériel de sensibilisation, de mobilisation sociale à l'endroit des communautés pour préparer l'introduction du nouveau vaccin. Et il fallait également insister sur la formation des personnels, des maternités à la vaccination et au remplissage des outils de gestion du PEV, parce qu'ils n'étaient pas astreints à cette tâche auparavant. Diapositive. Donc voilà, c'est ce que je voulais partager avec vous. Comment au Sénégal, le CCVS a participé au processus d'introduction de la vaccination contre l'hépatite B à la naissance. Donc je vous remercie et je suis à votre disposition pour d'éventuelles questions.
Thank you so much, Professor Anta. That was a very informative overview. Went into great detail to for all of us to understand the process in Senegal to begin the implementation of HepB birth dose vaccination. If you do have any comments or questions, please put them in the chat. We'll be having a more open discussion in a moment. We'll also be posing some questions for all of you to respond to. Now let's turn to Dr. Gona, who will bring us up to date on the NITAG process for hepatitis B birth dose policy development in Zimbabwe. Dr. Gona?
Thank you. Can you hear me?
Yes, loud and clear.
Okay, Henry, did you manage to get the other set of slides? Because there were some slide changes. I could share my screen, or you can use the ones that you have.
I think we can be able to share the new slides, as you said, and they've been projected.
You share the new slides?
Yes, yes, they're being shared.
Thank you. Yeah, go ahead, go ahead. I'm very happy to the organizers to have finally invited Zim NITAG, that's our acronym for Zimbabwe NITAG, to this very important series of webinars. We missed the two previous ones, but yes, I've been listening to some of the presentations and very, very useful. My job really has been made easier by the previous presenters, Abigail, CD, and Prof. Anita, sorry. Is it Anta? Sorry. Sorry if I pronounced it wrongly. We in Zimbabwe have, I'll tell you the story that we've gone through in our process. If people have to take away a message today, we did not have any problems with technical information or the processes. We made a decision 2 years ago. Our problem is implementation. So we'll go through and discuss some of the issues without going into too much detail about the whole process. I think by now people more or less understand the roles and responsibilities of NITAGs. Next slide, please. So that's our story. Zimbabwe NITAG was formed in 2011. Were re-established in 2016. And like I said, we've got the required expertise as per WHO guidelines. We have the ex officio liaison secretariat as per recommendation. We have the luxury of having extra, what we call NITAG coordinators. We've got a librarian who is very useful in assisting members in doing a literature search for whatever topic we attend. And we also have not secretary, but a human being, a secretary, who is actually a retired EPI manager who, with the librarian, they assist in arranging meetings, taking minutes, and also giving feedback to all members. Next slide. I think there's a delay in the way the slides are changing here. Have we gone to the next slide?
Yes, the slide titled HBBD presentation.
Oh, okay. There was some issue about funding. I think it's important to maybe other countries who haven't started their NITAGs, because people need to know how we are sustaining ourselves. Setting up a NITAG is the most difficult, or maybe also most expensive. The running costs are minimal. We are housed in the central vaccine stores, so we don't pay any rent. We had the initial trainings and orientation, which were assisted by the CIVAC initiative. This was to train the members on evidence-based recommendations. We had 2 trainings and an inauguration meeting. We also got assistance from Gavi to get us office equipment. We've got an address, we've got a physical space that we occupy, so we needed some furniture, and also a laptop, which is the one that I'm currently using. The running costs really are for meetings, be it local or international, in terms of capacity building for our members, both core members and liaison or ex officio. The coordinators are on a small stipend, which they get from funds from Gavi, and they are part-time because most of the time there isn't much to do. Next slide, please. Again, looks like there's a bit of a delay. But the recommendations that we have done, we have made as NITAG, we are recognized by the ministry, except maybe I can preempt, maybe the only issue is the COVID-19, where they have parallel structures. We'll go there on the last bullet. But for most vaccines, they take our recommendations. There's no recommendation that has been rejected by the Ministry of Health. And for the HPV introduction, this one was our first real technical output. And we made sure we did it properly. The hepatitis B birth dose, sorry, that is the one in 2018. Hepatitis B birth dose was our first one. It was done, I should say, very well. We also had the HPV introduction 2018, TT to TD, TD schedule 2019. We introduced the TCV 2019, but because of COVID and all other issues, things were postponed and we only launched it recently after a lot of postponement. And we have the IPV first and second dose. We also have managed to switch rotavirus vaccines from Rotarix to Rotavac. This is mainly to do with a switch for sustainability as we are graduating from Gavi eligibility. So we looked at the costs and many other factors. I did mention the COVID-19. There's an expert advisory committee, and they have been having more influence on the decision. Sometimes as NITAG, we only hear either as press releases or somewhere that this is the vaccine that is coming. And so those are the vaccines that we are using for COVID-19. And currently we're working on the Johnson & Johnson vaccine. This one, our ministry hasn't decided whether we need it on board or not. And we had a meeting yesterday, and we're currently compiling all the information, and we should be giving the ministry advice by Friday, tomorrow. Let's have the next slide. So since September 2018, this is 2020, we made the recommendation, followed the process, produced the technical dossier, which was taken to the then permanent secretary. In other countries, you call that the Secretary for Health. And but since then, nothing has happened. We're still one of the countries that have made a decision, but implementation is still zero. So in terms of the technical issues, I'll go briefly. This has been mentioned by previous speakers. What generates a NITAG agenda could be from regional or global recommendations. At that time, it was from the NITAG. The hepatitis B birth dose was topical. And we did the whole process, like Prof said in the previous presentation. We had a technical working group, and we used the typical recommendation framework where we looked at those 4 areas: burden of disease, vaccine and immunization characteristics, economic considerations, logistical and programmatic. Without going into too much detail, one thing I will mention is that we had an advantage because institutional versus home deliveries have been hovering around 84 to 90%. Of course, affected by COVID and user fees and all other factors. So we had that on our side, because if most or a significant number of women are delivering in institutions, we could actually manage to give the first dose of hepatitis B within the required 24 hours. We looked at vaccine safety, efficacy and immunogenicity, cold chain logistics, and co-administration. Some of the drivers for this program to take off is obviously availability as a monovalent, vaccine costs, sustainability, depending on the source and the cost, and also other hidden costs besides just the vaccine costs, training, and like I said, other hidden costs. The ability to give vaccine within 24 hours, to train people in the labor ward who don't normally give vaccines, also acceptability to the people and also to the mothers. Our source of information was obviously internet-based databases, PubMed, Cochrane, and also Hinari, WHO position papers, and SAGE recommendations, and obviously local data when available. Next slide. So the process, I think it has been mentioned, is when NITAG makes a recommendation, a technical dossier is presented to the policy makers. Starting in our situation, the secretary, permanent secretary, now the names have changed, we call them Chief Director of Preventive Medicine, who then takes it to the minister himself. And this is where we start having issues or problems. because at that time they thought, oh, lovely, this makes sense, but it's not a priority at the moment, which maybe at that time was debatable. It was before COVID. But at that time, we were having different set of, there was a lot of change at the top management team. We mentioned it in some of my challenges, where we would have permanent secretary changing, and don't want to make any commitments, where you have the minister also changing, a new team comes, and in the end, no one was committing. Even the Ministry of Finance was not committing to take this on board because they thought it would not be sustainable. And at that time, and I think it is still current, that the Gavi board said they will not support financing of the vaccine costs, which depending whether it's a multi-dose, 5 multi-dose or 10 dose, the price changes. But no one was committing to actually getting this vaccine on board, because again, going through Gavi transition. Next slide. So this has been our story, and to me, I would say frustration, because we're almost getting to 2 years down the line, and we still don't have implementation of a recommendation that was made in September, 6 September 2018. So some of the challenges that first, besides the decision at another level, which are the policy makers. From the technical side, we really wanted to do a prevalence study to really find out the prevalence of hepatitis B within the first 6 weeks. Because basically the literature, everyone is saying, yes, by the time you are 6 weeks, a lot of children already have been infected. We know we've got more of vertical transmission in this part of the world. We have some studies that were done. These were old studies, maybe outdated actually, and we couldn't do the seroprevalence study. But as part of our recommendation at the end, we actually recommended that at some point, I think it should be done, but we can make a recommendation at this stage. Just like we all know, the strength of your recommendation is also influenced by the strength of evidence. And without any doubts, the non-committal from the policymakers, from the ministry, government officials, was too much reliance on Gavi support. When they saw that Gavi is not doing this, maybe it's not a priority, maybe we're not ready, and that will be almost like that's where it dies, this issue of introducing hepatitis B birth dose to our newborns. And there were too many changes in the top management team. It was difficult to follow one thing that you had discussed and agreed on with one previous minister or permanent secretary. So it's really frustrating. Next slide, please. Finding the evidence is important. That's what NITAGs do. From SAGE to RITAG, when it's now at the NITAG level, you should have available data, because this is what drives you. This is what gives the community confidence, or even the policy makers. They'll get confidence if you are using the data that is collected from the people in the geographical country. Funding issues. Yes, that needs to be very clear, and people should take ownership. Government should take ownership rather than to rely on external, this particular case, Gavi funding. Programmatic issues, lessons learned, yes, we're ready. We made a plan from our recommendation framework how to deal with some of these issues. And the major thing, because all these lessons learned, one is feeding into the other. Just like the issue of sustainability. Once you commit, depending on your GDP, GNI, once you commit, you should be able to sustain. And all these ministers and chief directors, they were taking a responsibility, making a decision, because they didn't think that the country will be able to sustain this program. Next slide, which just says, thank you. This is the story of Zim NITAG. And like I said earlier, technically, we were okay, pass the baton stick to the other side, and then implementation 0. Thank you.
Thank you very much, Dr. Gona, for excellent presentation and really describing, the relationship between a NITAG and the Ministry of Health and that interaction that turns a policy into an implementation of an intervention. I think there's at least one question for you, Dr. Gona, in the chat. If you could go to chat and respond to that in the interest of time, that will be greatly appreciated. We want to take this opportunity to get others involved in the conversation. We have some, we've asked for other individuals from other countries to describe sort of their status of NITAG policy development for hepatitis B birth dose, as well as any of their perspectives of how that process is similar or different from what we have been hearing from Senegal and Zimbabwe. Henry, are you on the line?
Yes, I am. And yeah, it's, unfortunately, my camera is not working, but I can hear you all well clear.
Okay, one moment, please. Dr. Gona, was that you speaking?
Yes, it was me. The question is on whether other NITAG recommendations, for example, introduction of HBV, IPV, and TCV, which are Gavi funded, were implemented. Yes, they were implemented. The hepatitis B birth dose, I think, like I said earlier, the powers be, the policy makers thought it was not a priority, which was even put lower down when COVID came. So that was our dilemma. The others were introduced, like the TCV, because we had been having a lot of outbreaks of typhoid in the capital city, Harare, and also in a few hotspots within the country. Those were taken up easy by the policy makers, and the implementation is it's quite a high coverage at the moment.
Thank you. Henry, since you are on, please introduce our first panelist.
Thank you very much, John. So we have quite a number of participants that we want to get to hear their perspectives. We have Dr. Jean Kabore from Burkina Faso. Dr. Jean Kabore, if you are in this meeting, you could unmute yourself and say hi.
Merci. Je suis Jean Kabore, président du GTCV du Burkina à Ouagadougou. Je suis clinicien neurologue et je suis le président du NITAG depuis sa mise en place en juillet 2015 et j'ai eu le renouvellement des membres en 2019 et je continue de diriger le groupe. Nous avons eu, je dois remercier la coalition d'avoir invité le NITAG de Burkina à participer à cette réunion. On y apprend, j'ai appris beaucoup de choses. Le groupe technique consultatif pour les vaccinations du Burkina, depuis 2015, a fonctionné. Nous avons rempli les missions qui nous étaient assignées en émettant des avis qui nous avaient été adressés par le ministre. Il s'est agi dans un premier temps de nous prononcer sur la vaccination hors PEV. Nous avons eu à émettre un avis, des avis plus récents, notamment sur la vaccination, le suivi de la vaccination avec la rougeole, contre la rougeole et la rubéole. Mais nous avons... Oui.
Thank you. So next we'll have Professor Tiembre Isaka. Professor Isaka, please introduce yourself.
I'm not sure if Professor Isaka is on.
Okay, fine. The next on the panel is Professor George Ama from Ghana.
Hi, everybody. I am George Ama. I'm a virologist, an immunologist, and also a vaccinologist, very much interested in trying to get vaccines to all African children. I've been working mostly on the introduction of rotavirus vaccines to African kids over the last 20 years. Nice to meet all of you.
Thank you and welcome, Professor George Ama. We have Professor Rose Barnett from South Africa. Professor Rose, if you are available, you could introduce yourself, followed by Melinda Sachad, Dr. Melinda Sachad.
Hi, thank you. I was just battling to unmute. Hi, I'm Rose Burnett. I'm a medical scientist specialized in hepatitis B virus. I'm based at the Tshifaka Makgatha Health Sciences University, and I am a member of the South African Vaccination and Immunization Centre. I have been a NITAG member since 2017. Our NITAG is called, excuse me, NAGI, which stands for the National Advisory Group on Immunization. Thank you.
Welcome, Professor Barnett.
Thank you.
Dr. Melinda.
Hi, good afternoon, everybody. I'm Dr. Melinda Suchard, also from the South African NITAG, which we call NAGI. I've been a member a few years since before Prof. Rose Burnett. And South Africa has an interesting discussion, perhaps, to give to this afternoon's sharing session, because we have made a recommendation about birth dose, but our recommendation was not to implement. And I have a few slides if you would like me to present them just as an overview of what formed the basis of our recommendation. So we found ourselves in quite an unusual situation. It's not the first time the South African NITAG has made recommendations that differ from those of WHO. For example, we give measles vaccine at 6 months and 12 months. Our timing is different from that recommended. So we have quite a mature NITAG that has been advising and been reviewing local evidence for many years. And after review of the local epidemiology around hepatitis B, our recommendation was not to introduce. However, we have had some pushback on the recommendation because of the political pressure and the global sort of advocacy around hepatitis B birth dose. And certainly there are advocacy groups within the country that do push for birth dose, and there are high-level WHO and national and international meetings where pressure is put for birth dose. So in fact, our minister has signed up for birth dose, but on the basis of the NITAG recommendation, has not actually implemented, but it's sort of somewhere on the back burner, waiting depending on funding priorities. Thank you.
Thank you very much. Just one quick question for you, Melinda, is that how does the NITAG process start? Can the NITAG initiate that process, or typically is the process initiated at the direction or request of the health ministry?
It depends on the question that is being answered. There are some questions that have been initiated by the Ministry of Health, usually because of political questions that have been put to them. And I think that was a recent situation around mandatory vaccination, for example. NITAG was asked to prepare a recommendation on mandatory vaccination. And again, the recommendation was against mandatory vaccination. In the HepB question in particular, the push came from advocacy groups. And the advocacy groups were discussing, where to take their push for birth dose, and they were advised to submit to NAGI, and therefore NAGI considered the matter. And then NAGI made the recommendation, and in fact, the advocacy groups responded in writing to NAGI again. So this issue has come up in over multiple years at NAGI, with multiple rounds of documents and multiple rounds of communications. With the final recommendation going to the minister in November 2018.
Thank you. Thank you very much. I think we have a poll question. We wanted to create an opportunity for others to provide comments. So we have a link to a survey question. I think, can we put that in the chat, Lindsay, or how's the best way to make that available?
Yes, I just sent it around in the chat.
Yeah. So please click on that when you feel like you have the opportunity, and so we can hear from a greater number of persons. We have about 5 more minutes for the panelists. Any other questions you want to pose, Henry, or if others have a question for them or for the speakers, please put it in the chat or raise your hand. We'll do our best to recognize you. Thank you.
Thank you, John. I want to ask Professor George Ama, who is in Ghana, to tell us the current status of the NITAG activities related to hepatitis B birth dose vaccine, and to tell us what if they have already started discussing it, some of these experiences that are important lessons for others that can be able to learn from. Professor George Ama.
Thank you, Henry. We haven't started looking at it yet because it is the government, the Ministry of Health, that will send the information, the request to us. Then we begin the deliberation. But I've had informal discussions with the EPI, trying to find out whether they had any data on the burden and the sero-epidemiology that they could share. And unfortunately, that is not the case. And I think that will be a big challenge because our decisions will have to be on the evidence-based. And if we don't have that information, yes, of course, we can rely on other regional information and other international information, but it's not the same. And so I've always been thinking that in the recommendation, if you have to make any recommendation to the government to introduce the birth dose, we need to have some evidence-based information. And I think that is what I will also want to recommend, that the NGOs not only look at the introduction of the vaccine, but also look at the data capture system also. How can we improve most of these countries to collect the data that we need for the advocacy, the data that we need to try to shut down the hesitancy group, and the data we need to try to influence policy. Countries like South Africa have had it. They have a huge amount of information because there's been a lot of independent research in these areas. So it's much easier for them to take the decision. But if you look across Africa, look across West Africa, probably Senegal and Ghana and Nigeria that we may have. The rest of them do not have that capacity. And it's a big weakness that we need to. If we need to progress, I think that is where we should also look at and put more efforts. Thank you.
Thank you very much.
But in any case, talking about our NITAG, it's only 3 years old. We took almost 1.5 years to get our manuals and get an secretariat set up now. We have a secretariat housed in the epidemiology department of the ministry, and we have an executive secretary who takes care of all the issues there, and is being funded by the Ministry of Health. Thank you.
Thank you. Great. Just before we go to Rose and Melinda, I would like to hear from Dr. Jean Kabore from Burkina Faso about your experiences on hepatitis B, if you have had any.
Merci, nous avons certainement des choses à partager. J'étais allé très vite en besoin tout à l'heure quand il fallait se présenter. Donc, le NITAG de Burkina fonctionne depuis 2015. Nous avons renouvelé nos membres en 2019 et en juillet, nous avons reçu une sollicitation du ministre de la Santé pour réfléchir sur comment est-ce qu'il fallait introduire une dose de naissance pour le vaccin contre l'hépatite B. Et j'ai envoyé des diapositives à Nduguna, si vous les avez. Peut-être que juste, il y a 2 questions qui nous ont été posées et auxquelles j'ai répondu, si c'est possible. Sinon, juste pour dire que nous avons suivi le protocole.
I think for the interest of time, because I don't have them with me right now, can you go on, please?
OK, entendu. Nous sommes répartis en groupes de travail et nous avons suivi le protocole proposé pour les rédactions de notes de recommandation qui ont été dites tout à l'heure, à savoir l'épidémiologie de la maladie, les questions programmatiques, les questions économiques et puis les problèmes d'organisation. Les différents groupes de travail ont bouclé les revues bibliographiques et je dois préciser que sur le plan national, nous avons suffisamment d'expertise et nous avons quelques 2 ou 3 études épidémiologiques au niveau national qui donnent le taux, la prévalence de l'hépatite B au sein de nos populations. Donc, nous avions pratiquement toutes les données et tous les outils nécessaires. Les différents groupes ont bouclé les revues bibliographiques et nous attendons juste de réunir la plénière pour proposer le premier draft de la recommandation au ministre de la Santé. La question posée, c'est quels sont les challenges? J'ai déjà eu l'occasion de répondre à cette question et elle est commune à tous les NITAG, du moins en Afrique de l'Ouest que je connais, c'est le financement des activités. Donc, bien que les groupes aient fini leur travail, bibliographiques et de revues. La difficulté, c'est que nous puissions nous retrouver en plénière pour la rédaction du draft. La première raison, c'est la disponibilité des membres. La deuxième raison, c'est le secrétariat qui est surbooké au sein du ministère avec les différentes activités de l'heure. Il y a le Covid, il y a la flambée de virus circulant polio et toute l'équipe du PEV est occupée à résoudre ce problème. Et puis, la troisième difficulté, c'est le problème de financement qui fait que jusqu'à présent, depuis 2 mois que les équipes ont fini leur revue bibliographique, nous ne pouvons pas nous retrouver pour proposer un premier draft de cette note de recommandation. Je vous remercie.
Thank you so much, Dr. Kabore, for that brief overview. Next, I think we'll have Rose, Professor Rose, and Melinda. This is your time to tell us about your experiences.
Yeah.
Thanks. Just in response to George, yes, South Africa does have a lot of data on hepatitis B. And just to make it clear that although NAGI made the recommendations not to introduce the hepatitis B birth dose, there were some of us on NAGI who didn't agree with this because, and I was one of them. And the reason being that I believe that the epidemiology that we have got for South Africa shows that we should introduce the birth dose. And I was very pleased, when the Ministry of Health did not accept NAGI's recommendation. And in fact, the national guidelines that were put out at the end of 2019, those guidelines for the management of viral hepatitis actually do include the introduction of a birth dose of hepatitis B in 2019 into the national EPI, as Melinda said. However, at the time, excuse me, at the time of procurement of these vaccines, I think there was a lack of funds. 46 million rand was needed for those birth doses. And just to note that South Africa funds our own vaccines through the National Treasury. We are not eligible for Gavi funding. And I think because of NAGI's recommendation to not introduce the birth dose, and combined with the lack of funding, this led to the introduction being put on hold. Thank you.
Thank you.
Thank you. Yeah, go ahead, John.
Oh, that's great. I think please again, there is a survey question in the chat. Please respond to that. I don't believe I see any other hands, so I think we'll move on in the interest of time and hopefully have a few more minutes for discussion and questions after Henry's presentation. I think it's a good time we take a 30-second break to have a photo. Lindsay, if you can ask everyone to turn on their camera, we'll get a photo of the group, please.
Sure. Everyone wants to go ahead.
Thank you so much.
All right.
Looking good.
I'm going to do 2 or 3. I think we have 3 photo walls, so be patient. Here's the first one.
All right, very good. Yeah, this is my COVID transition. This is the most face-to-face I've had in quite some time. Hoping my reading.
One more second.
Got a few more cameras.
Okay, thank you all.
Thank you so much. Thank you guys, look great. All right, Henry, I'll turn it over to you.
Thank you very much, John. And unfortunately, I was not able to participate in the photo session. Lindsay, maybe you can crop one of my good photos and put it in that. My camera has a problem. I don't know what has happened. It's crashed and it's not working. But anyway, I can hear you all clearly, and I hope you can also hear me clearly. I want to take you through a toolkit that we are developing towards helping NITAGs in the introduction of hepatitis B birth dose vaccine. But in doing this, next slide, I'm going to go through a number of activities. I'm going to introduce you, and you have heard this concept before from previous presenters, the evidence recommendation framework. I'm also going to talk about the steps for building evidence to hepatitis B recommendation. And then I'll try and tweak that a bit to focus on hepatitis B birth dose vaccine. Then I will talk about some literature that I want to highlight on hepatitis B birth dose, again following some of the evidence criteria tables that you will get to learn from this presentation. And finally, I'm going to talk about some of the assistance that partners and the NITAGs can possibly get from the Coalition for Global Hepatitis Elimination. Next slide, please. So in the next slide, so the evidence recommendation framework is a structure to describe the information considered in making a recommendation for vaccination based on available evidence. It provides transparency around the impact of additional factors when considering a vaccine recommendation. Next slide, please. Critical questions when evaluating the need for vaccine introduction in the evidence to recommendation framework can be classified into 7 domains. The first domain is the public health problem. In this case, we are talking about mother to child transmission of hepatitis. We are talking about benefits and harms of the intervention. In our case, hepatitis B birth dose vaccine given within 24 hours of birth. We're talking about values, whether the target population feel that they need to have that vaccine introduced to them, including other stakeholders. Talking about acceptability, we're talking about feasibility, we're talking about resource use and equity. Next slide, please. Next, I will talk about the steps of building evidence for hepatitis B recommendation. Next slide. The ETR framework has 4 main steps. The first step is the question. The next step is the criteria, the evidence, and the recommendation as the 4th step. We'll go through each of these steps in the following slide. Step 1, the hepatitis B birth dose question. Usually, the Ministry of Health may ask NITAG to provide a recommendation regarding a broad policy question. It can be vaccine introduction or any other question that needs to get some policy direction, like it was presented to us by Dr. Abigail. Alternatively, a broad policy question can be developed by NITAG and discussed with the Ministry of Health. Such broad questions could be, for example, in our case, should a hepatitis B birth dose vaccine be introduced in the national vaccination program? Broad questions should be turned into specific questions using the PICO method, like Abigail did talk about. The PICO questions clarifies the questions and provides guidance on the search for evidence on benefits and harms of the proposed intervention, or in our case, the hepatitis B birth dose vaccine. Next slide. The PICO question comprises the targeted population, in our case, newborns, the vaccine intervention, in our case, first dose of hepatitis B birth dose vaccine, given preferably within 24 hours of birth, the comparison intervention, which could be you might decide that you'll compare it against the first dose of hepatitis B that is given together with other vaccines, the pentavalent, at 6 weeks and depending on your country schedule. And then the outcome, which could be either seroconversion to protective antibody levels or prevention of mother-to-child transmission of hepatitis B virus. Incorporating these PICO components, the PICO questions could be, next slide. Yeah. So in the second step in the ETR framework is determining the criteria on which evidence, on what evidence NITAG will collect in guiding a recommendation. Next slide. There is a generic evidence table that NITAGs can adapt in formulating the criteria. The table shown in the slide contains elements of data for consideration for each of the seven. This particular talks about the first domain, but we have elements for each of the 7 domains. The first column lists the elements that are considered in this case, the public health problem domain, which include burden of disease, clinical characteristics of the disease, use and cost of healthcare, the alternative preventive and control measures, the regional international considerations. These, like I said, are generic and can be adapted to suit the NITAG needs. So the NITAG can be customized based on NITAG's preferences in the next slide. And specific data gathered are listed for each element. Next slide. NITAGs should also agree on how to rank evidence that they will collect in terms of how it will influence the outcome of their decision. The ranks include critical for decision making, important but not critical for decision making, or not important for decision making. Ranking will guide data collection, emphasizing on data on critical and important outcomes. For example, you will not want to wait for 6 months to gather information on an element that is not critical. Next slide. This slide shows an example of domain 1, adaptation to the generic table, evidence table, with examples of specific data, their ranking in terms of how they will be influenced the outcome of decision to recommend hepatitis B birth dose vaccine introduction. And this, like I said, this is just an example. Next slide. Once the criteria is agreed upon, the next step is gathering the data, assessing, analyzing it, and synthesizing it, and preparing background documents. Next slide, please. This slide shows examples of published literature to hepatitis B birth dose for each of the 7 domains. The selected publications should be evaluated to determine the validity of their conclusion. For example, if you're talking about public health problem, hepatitis, you might want to refer to the Global Hepatitis Report or the status of hepatitis B control in the Africa region, which is actually published and available in the literature. There are many other of these examples, and some of them I'll highlight in subsequent discussions. Next slide. The final step in the evidence to recommendation framework is to discuss and vote on the final recommendation. Like it has been said in previous speakers, NITAGs have to agree, and the recommendation is dependent on what they find as evidence to support it. Some of these recommendations are desirable, and they will make a strong recommendation in favor of the question that was posed to them. Others are unfavorable, and they might decline, like we had in the South African example. Others might want to get more information to be able to get a concrete basis that they can make their recommendation. Next slide, please. Next, I'm going to highlight some literature highlights on hepatitis B birth dose vaccine. Next slide. And I have tried to highlight these based on the domain areas. So in the first domain, the public health problem, we are going to talk about the hepatitis B burden. So Africa, like I had said earlier on, we have recent estimates now on the burden of hepatitis B in Africa, estimated at 82 million people having chronic hepatitis B in Africa. Next slide. The prevalence of chronic hepatitis B in Africa also ranks second highest to Western Pacific region at 6.1%. It is also estimated that about over 87,000 people die of hepatitis B related complications in sub-Saharan Africa. Within the continent and among pregnant women, hepatitis B surface antigen prevalence is highest in Central Western Africa compared to other regions. Mother-to-child transmission of hepatitis B virus mainly occurs during birth. In utero, transmission accounts for only 2% of transmissions. So the bulk is actually during birth when the child is being delivered. The risk of maternal to child transmission is highest among pregnant women who test positive or have high viral load of hepatitis B virus in their system, or they test positive for hepatitis B E antigen, which is a surrogate marker for hepatitis B viral load. And it can be as high as 70 to 90% if they are positive, and less than 10% if they are negative. Next slide. More than 90% of hepatitis B infected newborns remain infected. That is, they have chronic infection, resulting in 1 in 4 dying of hepatitis B related liver disease like cirrhosis and hepatocellular carcinoma later in life. Next slide, please. Next, I'm going to talk about domain 2, benefits and harms of vaccine, highlighting some of the literature available. Perinatal transmission accounts for 20 to 40% of hepatitis B virus infections. A timely hepatitis B birth dose vaccine alone prevents up to 75% of perinatal hepatitis B virus transmissions. Hepatitis B birth dose also protects the infant at risk from household exposure after the perinatal period. WHO in 2009 recommends a timely birth dose for all newborns, preferably given within 24 hours of birth. Next slide. I'm going to combine domain 3 and 4, talking about values and accessibility. There are certain studies that have been conducted in Africa and in specific countries looking at values and accessibility of hepatitis B birth dose vaccine and aspects related to that. For example, in Cameroon, there is increased awareness of hepatitis B virus that is needed among pregnant women and other risks about vertical transmission to make them increase demand for the vaccine. In Nigeria, hospital delivery, attendance at antenatal care, and post-secondary education and knowledge of immunization schedules were factors associated with timely presentation for the birth dose vaccination. In Uganda, another study reported that there is need for continuously engaging stakeholders during planning to address concerns to raise confidence and maximize vaccine uptake. Next slide. For domain 5, about feasibility, there are several studies too that have explored this domain. Use of controlled temperature chain provides a cost-effective solution to overcome coverage barriers, especially associated with children being born out of hospital. Those are some of the strategies that could be put in place to access them. Addressing staff perceptions lack of outreach programs and babies being born outside health facilities may accelerate hepatitis B birth loss vaccine, as was reported by a study that assessed 5 countries in Africa. Next slide, please. Hepatitis B birth dose has also been found to be cost-effective in several studies, as shown in that slide. Next slide. And we have, there are proposed strategies to ensure that, that the vaccine reaches everyone who is in need, breaking all the inequity barriers that hinder access to this particular vaccine. Of course, educating mothers on the benefits of hepatitis B birth dose vaccine, like I mentioned, to create demand, positioning vaccines at labor rooms, to making sure that they're available within a timely manner. Those are some of the strategies, and that information can be found in several literature, including the ones that have been displayed in the slide. Next slide. Finally, I'm going to talk about some of the assistance that you could get from the Coalition for Global Hepatitis Elimination. Next slide. There is an evidence base that has synthesized some of these literature, and this is accessible via the links provided. We also have a help desk that answers quite a number of questions related to hepatitis B, the birth dose vaccine, again, accessible via the links that are provided there. And we are currently writing a draft birth dose literature synthesis, trying to highlight some of the key literature that is available there, and we hope that we will be able to put this in our website to be able to be accessible to everyone who needs to get this information. In addition, we're exploring potential of working together with our task force for global health counterparts in terms of providing technical support in trainings in future that whose need might arise in this process. Thank you very much, and we can have discussions and any questions related to this presentation.
Thank you very much, Henry. Please post your questions and comments in the chat, or raise your hand and we'll do our best to find you. But I did want to start with Dr. Sidi, since the WHO AFRO office and him and his colleagues have responsibilities for supporting the work of NITAGs. Just wanted to see if he had some comments on the toolkit that we are preparing to assist the process, and to get some comments as to how what type of toolkit would be most helpful for him in this effort. Thank you.
Thank you, John. I think that this tool will be very useful for the NITAGs in doing the recommendation. And I think that for the recommendation framework for the hepatitis B birth dose introduction in countries, it depends in many many things. First of all, it might be a priority for the API team. So, because as Professor Arma said, that the NITAG work on the request of the Ministry of Health, and this is very important. So we need this new generation of NITAGs identifying the priority topic on the API multi-year plan. So having this working group, the fixed working group regarding the priority topics of the API. And I think that for this tool also, we will need the local data. You see that the local data is very important, and Senegal, Zimbabwe, and the other countries give us a good experience in using local data to do a recommendation. But it is welcome also to have modeling data. If we have no local data, to have this modeling data. So what we will ask to a global hepatitis elimination task force, it is to help the countries to have local modeling data if the epidemiological, the traditional epidemiological data are not available in the countries. And for the NITAG, for the recommendation framework also need to identify which platform of maternal, neonatal, and child health exists in the country, how the vaccine given at birth are, how the vaccine work, the vaccine given at birth dose. For example, BCG and the first dose of polio, how the country is dealing with that. And as the colleagues mentioned in the chat box, I think that if we limited the evidence on the prevalence of the virus in the child, we will have a bias. It is important also to integrate, to include the prevalence of cirrhosis and liver cancer in the adult, because we see that in the evidence that the children infected during the birth are most at risk to develop this kind of complication. And I think that the NITAG recommendation at the hand can be an interim recommendation, and the NITAG, when the others, data, the lack of data will be filled, the NITAG can come up with another recommendation, a final recommendation to the Ministry of Health. Over to you.
Thank you so much. That's very, very helpful. And again, just to review some of the points Henry made, I mean, I think we see the role as helpful for the coalition to bring together the evidence base from these generally accepted international and regional sources, and then begin to work, at the national level in collaboration with the Dr. Seedy and his colleagues at the regional level and others to see how we can identify data at the national level that might be unknown but available, and then to look for opportunities to collect data where those gaps are identified and considered critical for the NITAG process. As Rania Toomey from CDC mentioned in the chat, that type of effort is going on in Ghana. And so Rana or Dr. George, I don't know if you want to talk about that process as an example of that. While we're waiting for that, another point raised by Professor Anta was, and was also just raised by Dr. Seedy, was the importance of acceptability by maternal and child health programs. And I was interested to learn from Dr. Anta if she had more comments about how did the NITAG process engage maternal and child health programs. I noticed that there was an obstetrician gynecologist on the NITAG, and was that an important step to identify and gain the acceptability of maternal and child health programs. Professor Anta, could you comment on that, please?
Merci beaucoup. Je peux apporter des commentaires. Donc, nous avons effectivement un gynécologue obstétricien, un pédiatre. Donc, tous les membres que j'ai cités participent pleinement à toutes les saisines. Mais comme vous le voyez, selon la particularité des questions, il y a des experts qui sont beaucoup plus impliqués que d'autres. Donc, en ce qui concerne l'introduction du vaccin contre l'hépatite B à la naissance, nous avons dès le début senti qu'il fallait remonter plus haut, travailler en amont, c'est-à-dire chez les femmes enceintes, au cours des consultations prénatales. Donc, c'est à cet égard que le gynécologue obstétricien a été d'une très grande utilité. Il nous a permis d'identifier là où il fallait, disons, travailler avec le personnel de santé d'abord, et ensuite avec les patientes qui venaient en consultation prénatale, notamment pour augmenter les taux d'accouchement dans les structures de santé, pour pouvoir donner la première dose dans les 24 premières heures. Et en cas d'accouchement dans les domiciles, essayer d'inciter les mères à venir le plus tôt possible au niveau de la structure sanitaire pour donner cette première dose. Ensuite, maintenant, il y a aussi un autre élément qui est, je l'ai souligné dans la discussion, c'est la recherche. Donc, j'insiste beaucoup. Le rôle, quelqu'un l'a dit ici, le rôle des GTCV, c'est un rôle plutôt institutionnel, mais étant donné que ces experts qui sont là-dedans sont des scientifiques, je pense qu'ils peuvent susciter des questions de recherche à partager avec les institutions de recherche, les universités, mais également eux-mêmes dans leur propre laboratoire, hein, ils peuvent débuter des recherches. Hein. Donc, c'était la question du professeur Tanda Khadje. Est-ce que nous, dans les GTCV, nous pouvons nous introduire, nous pouvons nous, disons, impliquer pour combler les gaps? Ça a été dit tout à l'heure, il y a certains pays qui n'ont pas donné en matière de prévalence de l'hépatite B. Des modélisations pourraient permettre à ces pays de bénéficier de l'expérience des voisins au niveau régional. Donc, nous sommes prêts. Est-ce que la coalition pourra nous aider ou bien d'autres partenaires à aller au-delà de juste des enquêtes de prévalence? Vous avez raison également en ce qui concerne l'hésitation vaccinale. C'est très important d'avoir les experts. Nous avons le gynécologue peut aider auprès des mères, le pédiatre également peut aider auprès des mères, mais il y a aussi la formation du personnel. Le personnel de santé, parfois on l'oublie dans la prise en charge de l'hésitation vaccinale, mais ce sont des relais très importants de l'information dans les populations. Si les personnels de santé ne sont pas convaincus de l'utilité d'introduire cette dose à la naissance, donc ils ne pourront pas relayer l'information auprès des populations. Alors, merci beaucoup. Ce sont ces constats que nous avons faits lors de l'élaboration de la recommandation. Merci beaucoup.
Thank you very much. Appreciate those comments. I don't know if our panelists have additional comments. I was interested to learn from Dr. Gona if he's still on the line. Hearing, the different parts of our toolkit for the NITAG process. Just would like to learn if you have any perspectives on, since you've gone through that process, are there any parts of that toolkit do you think are particularly important for the NITAG process based on your experience? Thank you.
It looks like he had to drop off, John.
Okay. Very well. don't know if any of our other panelists are still on, Dr. Jean, Professor George, or Professor Rose, or Dr. Melinda.
Thank you for the opportunity. I think this is not the right forum to get into nitty-gritties of why NITAG did or didn't make our decisions. I can see I'm very outnumbered by the hepatitis B advocates here who are very pro-birth dose. The point I want to make, though, is that empowering NITAGs means empowering them to make independent decisions. That's the whole point of having a country NITAG that makes local decisions. And if the push from the top and the advocacy from the top assumes that implementation should be as specified by WHO without regard for the NITAG policy, then the whole process becomes null and void. So I just wanted to give a different perspective from the South African NITAG. It is, of course, a heated discussion and a heated topic, and there are multiple opinions, and we may have to agree to disagree. But really the point is that if NITAGs are empowered to make decisions, then those decisions should be respected and of course can always be challenged, on the academic platform backwards and forwards. But the answer is not obvious before the NITAG has made the decision. That is the whole point of having a NITAG, to consider the local epidemiology and the decisions.
Yeah, thank you, Melinda. That's really a great way to end this in many ways. I mean, that is the whole point, is to get a great process going that really gets the evidence on the table for an objective review and deliberation. And then, as always in public health, and then how do you translate that evidence-based conclusions and recommendations into a public health action, bringing together the other components, that we're very familiar with in public health regarding political, financial, and community considerations. As I mentioned, the hepatitis B vaccination is a very powerful one, and we want to make sure it gets its full consideration in every country in Africa, and then do our best to help make that recommendation fully and communicate it so that it's the NITAG recommendation is fully understood. So we look forward to continuing to work with you in all of those different aspects of the NITAG process. So thank you very much for joining us today. We have a remaining poll just to get a better sense of how well this NITAG worked for you. If you have any other some comments about how we can improve this us convening and building this community practice, we very much look forward to that. Please also follow us on Twitter at Global HEP, where we'll be announcing the webinar in July to bring all the different aspects of what we've been discussing in these 3 webinars together, and then look ahead to see how we can continue to build a community practice in the future. Henry, I'll let you give us a farewell.
Thank you, John, and I would like to thank all the participants who have been able to contribute towards the discussion and also listen to the discussions that are going on in this particular webinar series. I think this is what makes this a very fulfilling exercise, building this community of practice, and your continued engagement in these meetings has been quite overwhelming to us, very heartening to us, and we really are happy about your participation. Like John mentioned, we are having our next meeting in July, and you are all invited. We'll be sending invites to everyone who has been able to participate here. And this meeting is really going to be talking about the roadmap towards hepatitis B birth dose implementation. We want to put together our minds and think about tangible aspects of the implementation activities that we can be able to offer either technical assistance, or even think about any research that might be needed in terms of offering support, and also getting this implementation of the hepatitis B birth dose into practice in most of the African countries that have not yet introduced the birth dose. We also would like to hear back about the toolkit that we are preparing, just to hear about what aspects that we can improve on it, and therefore we really welcome your comments and feedback. Finally, all the materials that we are presenting today will be available to you all. Will be in our website, and we'll have a synthesized document and also the recorded presentation, which will be available to you all. And lastly, I would like to thank you again. It has been a pleasure, and we wish you all the best, and hoping once the COVID situation cools down, we'll have a time to meet and have more personal interactions with you all. Thank you so much, and have a nice time. Bye.
All right. Keep in touch. Thank you so much.
Bye.